with all these new options coming up, we have now to decide how to sequence all our treatments, and this is difficult. But on the other hand, we also have to keep in mind that in general these patients are rapid progressors and have a short lifetime, and also are rapidly have rapid decrease in their performance status. So you cannot just decide I do first-line treatment, then do immunotherapy, and then see what I can give next, because you will lose a lot of patients who, after the failed effort to introduce immunotherapy, will not be able to get chemotherapy as a further line. So we really have to decide after the first line which is the treatment which I want to give to this patient already, and that can be based on things like rapid progressor, PD-L1 positivity, patient's own preference, which we also have to take into account.
There are also several data suggesting that we can use anti-angiogenics in first line and also in second line. In fact, if you look at the subgroup analysis of the REVEL trial, you can see that about 15% of patients were already treated with bevacizumab in first line. So in principle, we can use this kind of drugs everywhere in the treatment of this kind of patients. However, I think that the best place to use the ramucirumab will be the second line. I think that the story is quite closed for squamous cell carcinoma because the advantage of immunotherapy in this setting is very high. So I think that we have to talk again about on the adenocarcinoma. And for adenocarcinoma, I think that you have to look at the PD-L1 expression and then decide what to do. But I think that to avoid the combination therapy with docetaxel and anti-angiogenics could avoid a treatment option for a patient. So I think that although PD-L1 expression is not a good predictive biomarker, this is something, and I think that we must take care of this to decide all the treatment strategy from the first line to the end of the treatment of this kind of patient, and trying with all this kind of information to give all the opportunities for this kind of patients and to give all the treatment as possible in their life. And there is another point that must be very carefully considered, and this is that possible pembrolizumab became the first-line treatment for patients strong expressors of PD-L1. So all the patients who were strong expressor for PD-L1 and were treated with immunotherapy in first line, I'm sure that they will receive chemotherapy plus anti-angiogenics as second line, if the performance status will permit this.
Sequencing would be to save it for the second or more line, and I would use ramucirumab in combination with docetaxel in the second or more line of therapy. And again, when you would use immunotherapy is the variable there. And most of the time now people are using immunotherapy second line, so it usually becomes a third line combo.